So welcome to our webinar for today. My name's Claire Brewster and I'm from the National Stroke Clear team. I'll be hosting today's webinar and we'll be discussing our learning from the Lincolnshire Stroke Programme project, and we'll preview our new stroke toolkit as well, which will support sites in transforming their stroke care. This webinar is part of our Clear Impact webinar series, which brings together transformation with project sites and helps to share learning and show the impact of their work. We are recording today's webinar and that's so that we can share it afterwards, not only on our website but across networks again for people who can't attend it. So if we just move on to the next slide, just a big thank you to all the speakers that are attending and speaking today at today's webinar. Thank you to Michelle Long for coming along and talking about strategy in stroke care. She's our National Speciality Advisor for Stroke NHS England. We've also got representatives from Lincolnshire. We've got Dr. Abdul El Marani, who's a clinical lead and consultant in stroke medicine. Amy Evans, who's a clinical service lead out in community in Lincolnshire Community and Hospitals NHS Group. And Sarah Hunter, who's a consultant stroke ACP in Lincolnshire. We've also got part of the project team, Anna McCower-Jones and Dr. Dan Ratnaraj, who's both work for the National Clear Programme. I'm just going to move on to the agenda. Next. So this is what we'll be talking about today. I will give a quick overview on the National Clear Programme. Then Michelle will talk about transforming stroke care as a national priority. Abdul will then talk about the context in Lincolnshire in relation to stroke care. Anna will then present the Lincolnshire Stroke Project, and within that she will explain the findings and the recommendations and potential impact. We will then have a discussion with Amy and Sarah, and they will talk about their key learning from the project from a clinician point of view. And then Dan will present the toolkit. We will then have time for discussions and questions and answers. So just moving on to the National Clear Programme. I'll just move on to the next slide. The Clear Programme was originally developed in partnership with Health Education England and is sponsored by NHS England Regions and Systems. We empower frontline clinicians to design innovative new models of care and workforce. And Clear is hosted and delivered in partnership with East Lancashire Hospitals NHS Trust. Move on to the slide. Thank you. The Clear approach. So we have a unique methodology when we approach any project work with transformation, and that has 4 key stages: clinical engagement, data interrogation, innovation and recommendations. And within those 4 stages, we like to understand demand and lived experience of frontline staff, review and perform in-depth analysis both of quantitative and qualitative data, and then review and understand key challenges and work with frontline teams within that service to co-develop innovative new models of care and workforce. We then publish recommendations and potential outcomes and share with the stakeholders. Just move on to the next slide. Thank you. This is just really an illustrative map of the projects that we've done so far. First project started off in 2019, but we've done now over 90 projects within England, and they have all been supporting the NHS in key priority areas. And as you can see there, we're slowly turning England blue, but we do cover an awful lot of specialities within those transformation projects. I'm now going to hand over to Michelle and she's going to talk about the National Stroke Programme. Thank you.
Hi everybody, thanks for inviting me to come and speak today. For those of you that don't know me, I'm a jobbing physio working down in Sussex, and I've been the National Specialty Advisor for Stroke for just over 1.5 years now, and have been working with Clear on the project in Lincolnshire to look at how we can redesign pathways and understand our provision. So if you go on to the next slide, please. So stroke remains a priority for the government and the national team. It's a leading cause of adult disability. We know, based on the 10-year health plan and the government's ambition to have modern service frameworks, that we have a CVD, so a cardiovascular disease modern framework, which is going to be inclusive of stroke, and the intent of that will be to drive down mortality and improve outcomes for our stroke survivors. This necessitates delivery of an organised stroke care across a pathway which is inclusive of prevention, pre-hospital triage, acute interventions, stroke specialist needs-led rehab, and long-term support for those that need it. So it's really, really key that we take a pathway approach to any kind of stroke provision that we're providing. Next slide, please. The National Stroke Service Model and the Integrated Community Stroke Service Model set out the policy that we want our systems to adhere to and expectations for delivery of that organised stroke care. Central to these policies is a modernised workforce and modernised ways of working. So what you're going to hear today from Clear is things that they've been doing, working with Lincolnshire to identify opportunities for that workforce modernisation and new ways of working. Next slide, please. Okay, so as the national team, we've been focused on improving delivery of thrombolysis, thrombectomy, and the integrated community stroke service model for delivery of that needs-led rehab. And central to these aims has been support to systems to deliver data-driven QI, so quality improvement. And one of our aims has been able to capture that data and insights from the data to inform service delivery across the whole pathway. And you can see here in the slide the aims that we had for the 25-26 year, and improving data and information is front and centre of those aims. Next slide, please. So we have, as I'm sure many of you will know, refreshed the SNAP data set so that it includes more community data and more outcomes. And we've got lots of stroke data. And the problem we've experienced, and the guys in Clear working with the Lincolnshire team experienced this firsthand, is that we've got lots of data, but it's not always joined up to any other data that's available, and it's not always reviewed by our teams delivering the care, or for that matter, the systems supporting them to deliver the care and improvements that we need. You might ask why that's an issue. Next slide, please. Well, this very, very, very busy slide, not designed by me, is our programme on a page for 25-26 from the National Stroke Team. And if you can squint well enough, you'll be able to see that our targets for access to early supported discharge and community stroke rehab, and our targets for thrombectomy and thrombolysis haven't been achieved, in essence. So we had a 70% access target for ESD and or community stroke teams, and we haven't achieved that, and we haven't achieved our thrombectomy or thrombolysis aims either. This means we aren't realising those benefits of organised stroke care, such as reduced disability, reduced dependence on care, and reduced mortality. More importantly, we're failing our patients. So we know that some systems have invested in improvements whilst others haven't, and that this is resulting in unwarranted variation. So if we go to the next slide, please. So you can see here that we've got two maps. The map on the left is our access to early supported discharge and community stroke teams, and the map on the right is our percentage compliance with access to the integrated community stroke service model. And you can clearly see that there's inequitable provision. So green would represent, the dark green would represent us achieving targets, so 70% access. And the lighter green, the ambers and the reds are not achieving anywhere near target, and the dark amber and red is less than 50% compliance. So you can see that we're transitioning from fragmented care, early supported discharge and CST, to non-fragmented care with the combined teams. So you can see there's less red on the left than there is on the right, but there's still massive unwarranted variation that we need to address. Next slide, please. So in light of the fact that organised stroke care is a pathway with multiple moving parts, and that our teams don't always find it easy to use the data and to inform QI, we commissioned Clear to develop a toolkit which supports teams to visualise their cross-pathway data. And it's a really unique approach because it is a cross-pathway approach. So today you're going to be introduced to the toolkit. It's been developed and tested in one site, which is Lincolnshire, but we would like to work with you to test it in other systems in order to understand if assumptions that have been made in the Lincolnshire system are transferable. The toolkit's going to allow you to understand your data maturity. It will help you improve access to data insights, reduce the time needed to review the data, and will help you make sense of your data. I'm going to hand back over to Claire now to tell you more about it.
Thanks, Michelle. I'm going to introduce Abdul now. He's going to give us some context in Lincolnshire around the challenges, demographics, and just aims of the project.
Thank you very much. I'm having a little bit of difficulty with my camera, so if I start disappearing or anything else, I'm not turned into Darth Vader. As you can see from the slide, Lincolnshire is a large county. Can you hear me okay?
Yes, we can. Yeah.
Yeah. So we have, just for context, we have 4 counties in East Midlands. Lincolnshire is larger than the other 3 combined. The population density is about 133 people per square kilometre, which is some of the lowest in the country. The average for the East Midlands is about 400 people per square kilometre. So that presents its own issues with access, transport, and what comes with it in terms of delivering a service that is an emergency. At least from the front door when we have to see people very, very, very quickly, which kind of translates into the thrombolysis figures when you have distances. The other side of it, we used to have 2 stroke units in Lincolnshire, but we had a public consultation, we had COVID, and we had to reduce our provision to a single site service, which again created its own problems with availability of beds, staff, and access. Obviously, the availability of beds impact on the amount of time people spend on the stroke unit. We have known from several trials, from guidelines, from everything, that the best place for a stroke patient to be is on the stroke unit, being looked after by the stroke team, rather than having to be admitted through a medical admissions unit, clinical decision unit, and ending up on a geriatric ward or a general ward. The outcomes are always better, and I'm sure my colleagues in CLEAR will explain that to you in terms of the data that we have from Lincolnshire. Another indicator of good stroke care is how long do stroke patients spend on the stroke unit. Unfortunately, because of the limitation of beds, we have to move people to other parts to give the acute patients the opportunity to have care, which impacts on their length of stay and the amount of time they spend on the stroke unit. We also have an issue with discharge delays because of provision and the impact of increased demand on the service on one side, and the availability of people being fit enough to go home or receive the therapy. The capacity for the community team is exceeded in terms of the demand that's put on it. Next slide, please. So what are we delivering at the moment? Currently, we are in a process of transition to having an extra stroke bed area or a new HASU, but our current provision is a 5-bedded HASU and 23 other beds divided between rehab and sort of acute and rehab and discharge planning. We went through a national program called TASK, which is improving thrombolysis. So that moved our thrombolysis figures from about 4% to about 10% during the project. And that has improved our outcomes as well, because, as I'm sure you all know, patients who receive thrombolysis have better outcomes on average, and reduced disability and reduced length of stay, also reduced complications. So our thrombectomy service is in Nottingham, which involves transfer, liaison with the ambulance service for patient transfer, as well as an hour's journey to get there. However, our thrombectomy figures going from Lincoln and coming back to Lincoln is within the national average. In terms of the beds on the hyperacute stroke unit, they're almost always occupied, and we exceed that because obviously that's the provision that used to be for the Lincoln area before we shut the unit in Boston. So we're kind of serving a population of the whole county, which is about 800,000 people, out of a 5-bedded unit. The new HASU unit, which should be ready by the end of this year, should solve that problem because it will have 8 fully staffed, monitored HASU beds. The other beds obviously are used by step down from HASU, step down from thrombectomy, and the general rehab, which means that we always have outliers, and that is a big problem when you can't smooth out your discharge pathway. You always have people who are waiting to go, not completed their rehab journey, but there's no room for them to be on the stroke unit. I'm not going to go too much on the community hospitals because I know my colleagues are here. Amy is here, who will give further and better detail than me. But it's the loop in terms of making sure that the patient journey is seamless, is in the process of working. What we have benefited from working with Clear is the fact that we worked as one team, which allowed the community team to see how we work and allowed us in the acute site to understand the provision and the difficulties that they have. I think that's my last slide.
Thanks, Abdul.
I think so. Thank you.
Yeah. We're going to move on now to the actual findings from the Clear project, and Anna will go through that. So over to you, Anna.
Thanks, Claire. We go on to the first slide. So I'm going to try and condense over a year's worth of work into 10 minutes for you, so bear with me. This will be quite high level, but we started with clinical engagement, which is our usual approach, as Claire described, with the Clear methodology, and we carried clinical engagement out between December of 2024 and January 2025. And as you can see from this slide, we spoke to a lot of people across the entire pathway, so from pre-hospital all the way through to the community, and we were also able to meet with patients and families as part of the Stroke Association patient support groups, which was really valuable. We mostly spoke about patient pathways, referral processes and service provision, but particularly about challenges that exist already across the pathway and any opportunities for improvements or sort of innovative ways of working. Next slide, please. So after carrying out a thematic analysis of all those conversations, these were our sort of 5 key themes, which I don't think will be, there won't be any huge surprises to sort of the clinicians or managers in the room. The first one was about patient pathways and processes, and in particular, making sure that pathways and processes are really clear for staff and for patients to reduce bottlenecks in pathways. The second was about roles and responsibilities and really understanding each other's services and the pressures that each service is under and the nuances of each other's services so that any barriers can be understood and overcome. The third was about group service integration, and this really was about making sure that we're evaluating the pathway and that the pathway works as one pathway, not as a series of siloed services operating under different organisations, which fits really nicely with what Michelle was saying about taking a pathway approach to stroke care. Our fourth theme was about estates and technology, either not having enough estates and technology, or where there are estates and technology and not being the right estates and technology for patients or for staff. And finally, a big one that encompasses most of our Clear projects was around workforce and either not having the right number of staff to deliver services or having not enough appropriately skilled staff to deliver stroke rehab or acute stroke care. Next slide, please. So as we've alluded to, we did a huge amount of data analysis. We pulled data from national commissioning data sets and combined those with SNAP data across the entire pathway so that we could follow patients from attendance in ED all the way through to discharge in the community. The first piece of data to talk about is around ED in the front door, and this was taken across 2024. And Lincoln had around 1,800 attendances of suspected stroke and TIA with a 66% admission rate, which equates to roughly 3 daily admissions. But interestingly, over half of the patients that were attending ED with strokes had low severity NIHSS scores. 63% of patients attended in hours, and it was approximately sort of 40 minutes from clock start to being seen by a stroke skilled clinician, although there's been improvements in that time since this data was extracted. And finally, for patients attending with stroke, their ED length of stay was very long, between 9 and 12 hours. However, if patients were being admitted, their length of stay in ED increased by 3 hours, which really reflected difficulties in flow in accessing HASU beds on the stroke unit. Next slide, please. So then we looked at stroke inpatient journey, and we really wanted to understand the impact of outlying patients, because as Abdul's already said, we know that the best place for patients who've had a stroke is on the stroke unit. And what we found was that patients who are transferred from the stroke unit to an outlier ward during their stay have an increase in length of stay of 16 days. And that's compared to an 8-day length of stay for patients who are exclusively managed on the stroke unit. And we also saw that half of stroke patients were moved at least once during their stay, which increased their length of stay anywhere between 8 to 32 days. And we also saw that patients who were outlied received 45% less therapy time, which potentially also explains the reduced length of stay of patients in the stroke unit. But we did see that one strategy that really worked was cohorting outlying patients onto one ward, and that seemed to save approximately 2 bed days for patients on Burton Ward. Next slide, please. And then moving on to community services, we really saw the demand that was being put on community services through the data. So in terms of community hospitals, we've seen a 47% increase in admissions to community hospitals for stroke rehab since 2020, which had resulted in a 15% increase in length of stay across the same time period. Also reflecting that patient complexity was increasing, with patients presenting and requiring inpatient rehab with higher severity and IHSS scores. In terms of the community stroke service, they'd also seen an increase of 35% in demand since 2020, and that had resulted in a nearly 50% decrease in the number of face-to-face contacts that patients were receiving since 2022, which really highlights the complexity of the patients that were being seen in the community, and how patient-facing time was being diverted because of the need for sort of case coordination and sort of non-clinical tasks. We also saw that there was a 4-bed deficit in community inpatient rehab beds for 2024, which we are fairly sure is an underestimation, because it was based on existing demand and referral patterns. Next slide, please. So from that data, we thought about what we could implement that would be sort of fairly quick and start to implement some change across the pathway. And here you can see just a few of those quick wins. But just to highlight a few, we looked at ring fencing resus beds in ED and EMAS crews to improve repatriation from Nottingham, extending therapy working hours. On the stroke unit, we did a lot of work around communication, board rounds and huddles, and how we could reduce administration time for therapists and improve MDT working. Out in the community, we also looked at reducing administration time and sort of initial assessment time, and providing consistent messaging to patients about driving advice post-stroke. And out in the community hospitals, we really focused on providing equity of care between the acute service and the community hospital services through orthotics provision, digital solutions, and also hopefully ring fencing stroke rehab beds to enable better flow. Next slide, please. So these were our final sort of really chunky recommendations, and this is obviously going to be a very high level overview of these recommendations, but there's a lot more detail that went into them. The first one was based off of the ED data, where we saw that patients, over half of patients were presenting with low severity strokes. And so we've recommended establishing a virtual stroke ward to avoid admission for patients with a low risk stroke and free up capacity on HASU. We also looked at streamlining infection prevention procedures for repatriations from the National MT Centre, enabling patients to return to a normal bed rather than having to be isolated, because we knew that this could extend length of stay, reduce engagement in rehab, and cause delays in repatriation. We've also recommended establishing a mimic pathway to reduce inappropriate admissions to the stroke unit, because we knew from the data, again, that across almost every day of the week, there's a mimic patient on the stroke unit taking up capacity. We also recommended early identification of patients at risk of becoming or being complex discharges, including targeted adult social care input to try and move the needle forwards early on discharge processes. We recommended consolidating existing inpatient rehab beds that exist across 4 community hospitals into one specialist stroke rehab unit to really enable targeted rehab approach and consolidate specialist skills and workforce in one site. We also saw that complexity has increased across the pathway, and so clinician time is really being taken away from delivering rehab and acute care and being put into case management and coordination of care. And so we've recommended creating a stroke case management team to take some of that burden off of the clinicians and also improve flow across the pathway and patient experience. And finally, recommended optimising processes within the community stroke service, particularly things around handovers and referrals to improve flow. Next slide, please. So then we started thinking about sort of how we could present this in the form of a business case, or how we could reflect these impacts in a way that would sort of continue investment in the stroke pathway. And that's what this slide is really showing. So through the reduction of bed days or releasing bed days through improved flow, you can see here that if most of the recommendations were implemented, there's a potential opportunity of nominal cost savings, i.e. cost savings released of £1.4 million across a year. But really, most importantly, is that around 4,000 bed days could be saved or repurposed for patients to stay on the stroke unit and reduced outlying onto other wards that we know increases length of stay. So I think I'm going to hand over now to Amy and Sarah, 2 of the clinicians that we worked with in Lincoln, to talk to us about their experience of working on the CLEAR project.
Hi, thanks, Anna. I'm going to start and then hand over to Sarah. So I'm Amy, I'm a clinical services lead for the Community Stroke Service in Lincolnshire. So Sarah and I have pulled together a few things. If we can just pop onto the next slide, sorry, Namisha. Just a few reflections from our learning from being part of the project. So one of the biggest benefits we felt taking part in the project was getting that much clearer system-wide view that we gained from the whole pathway by working together across this. So although we understand our own teams very well, the work created that opportunity for us to step back and look at how all parts of the pathway function end to end, so that we could really look at what the opportunities were there. It helped us to see where that some of the pressures sat, so whether that was around sort of referral spikes or delays in handovers and bottlenecks that people are experiencing. We might not usually notice them when we're focused on that day-to-day delivery, but this gave us the opportunity to recognise where they were and gained more insight into the interdependencies between the teams and how a change in one area or a challenge in one of the area directly impacts the other areas, which I don't think we were perhaps as aware of before that. And it's given us a much deeper appreciation for the work that colleagues do across the system. So really understanding those roles and responsibilities across the different areas, becoming more aware of the volume and complexity that people were dealing with. And that's really helped to build that empathy and shared understanding of those pressures, so that we can look at how we work together to improve the pathway. So that's really given us those stronger relationships and networks that we now have to work together. It created that space, really. I suppose it gave us an opportunity to talk openly, build trust and understand different perspectives by stepping away a little bit from some of the pressures of clinical tasks and operational deadlines. I think what's really key to us is that that's continued. So although those networks sort of developed through the project, they haven't stopped. So in terms of the community hospital beds and the development around those beds that Abdul made reference to, colleagues are still reaching out now to each other for advice, share learning and sense check some of the decisions we make around the pathway, so they're not making those isolated decisions or assumptions around how that works. I think the other big learning was really insightful for us was the valuable aspect of having support from the project team around the data and the external data insights. So I feel like the team were able to look at the data with a fresh pair of eyes, so maybe free from some of the assumptions and internal pressures that sometimes I think influence how we interpret information. We were working quite separately in some aspects before this, so it's helping to look at that whole pathway data. I think having that access to a broader range of sources, different tools to analyse that data that we might not have capacity for internally, has helped to highlight some of the patterns and variations that we just hadn't recognised before. I think sometimes those findings have validated what we already suspected were happening, but in other aspects it's challenged us to think about some of those assumptions we've held for a long time, maybe where we've viewed things in a little bit more of a biased way, and it's allowed us to maybe think about what does that modernised approach look like going forward. So yeah, I think that's the 3 points for me, and if I pass on to Sarah.
Thank you, Amy.
That's okay.
My name's Sarah Hunter. I'm a consultant stroke nurse at Lincoln. And just quickly, 3 points from me about pathway-wide opportunities. So as we've mentioned, the clinical engagement feedback gave us real insight into each other's processes and challenges across the whole pathway, enabling us to see emerging themes and areas for improvement. It was this joined up insight that helped us understand where change would have the biggest impact and really reinforce the benefits of thinking as a system rather than in isolated teams and in silos. And it was some of the quick wins that really streamlined some of the processes, removed some duplication and released clinical time. During the innovation stage, we drew on individual ideas as well as looked at how other specialities dealt with some of the challenges that we were identifying and came up with possible solutions to these challenges and create better ways of working. In regards to the need for senior level engagement, upon reflection, success and progress is linked to consistent support at that senior and strategic levels. Initially, we did have senior stakeholder engagement and presence, but as that support slowed and organisational priorities shifted, the progress has dipped, and this can be challenging to teams and personally, as we found that we had to revisit what was needed to keep momentum and retain engagement and interest levels. Specialist teams working differently and stretching and flexing to better services can only go so far till investment is required. Initial financial investment may be required to create savings and better patient experience in the future. And this experience has highlighted to me for the need of clear sponsorship for the whole project and timely decision making. In regards to sustaining staff engagement, it can be very difficult at times to keep that engagement during periods of operational pressure because of competing priorities, reducing capacity for engagement in the improvement work. I believe it's important to have that regular communication and visible quick wins that essentially sustain the engagement. So for me, this project has clearly identified ways in which we can make improvements for our stroke patients, and the process was insightful and initially empowering. But anyone wishing to undertake this journey needs to ensure senior level buy-in with realistic expectations of prolonged support and possible investment to see better pathways and cost savings. I'll hand over now to Dan, who's going to show us the stroke toolkit.
Thanks very much, Sarah. Just share screen. I think we have one more slide actually, which is just an introduction to the toolkit. So we can have that up. Perfect. Thanks very much. So this is a little bit of background about the toolkit. So obviously there was the national ask that Michelle mentioned to try and spread and adopt some of the learning from Lincolnshire to other sites around the country. And really through the work that we did, we gained a really good understanding that data and data literacy were really key to key factors in underpinning sustainable transformation. We also identified the benefits of joining SNAP data, which is something that all stroke units are already doing, with national commissioning data sets, which again is data that is readily available to all hospitals around the country. So we're really hoping that the toolkit provides the foundations for repeating the process in other centres and offers teams the opportunity to benefit from the learnings that we took in Lincolnshire through the clear methodology on a national scale. So I will share screen now. Hopefully this works. So this is our stroke toolkit. Can everyone see it?
Yes, we can.
Yeah, perfect.
Yeah.
So I won't go through the entire thing because it's reasonably lengthy, and it would be good to have sort of feedback and questions at the end. I'll just take you through kind of the general architecture of how it works and how it might be used by somebody. The other thing I will say is that this will be available on the NHS Learning Hub in the near future, so that will be kind of where you'll go to for accessing it once it's live. So we have the banner along the left-hand side here. I'll just take you through kind of bit by bit. So we've got the kind of the aim of what the toolkit's for, a little bit about what CLEAR is for anyone who didn't attend the webinar, and to hear Claire's introduction. A little bit about the national context in stroke, again, so covering some of the areas that Michelle had been talking about. A little bit more of a deep dive into what we did in Lincolnshire, which was kind of described by Abdul and Anna and Amy and Sarah there. And then really to the main meat of the toolkit, and where this is the bit that we're hoping kind of most people will be most interested in. So a little bit of an overview of kind of taking you through the CLEAR methodology yourself. So thinking about clinical engagement, data analysis, innovation and recommendations, and how you might go about doing that, particularly on a stroke focused project in your own service. We go into kind of more detail about who you might want to think about speaking to within your stroke services, the kinds of questions you might be asking. Just try to uncover as many kind of useful insights that will help guide you when it comes to the data analysis. This is the bit that I really want to focus on today, because this is probably the bit that sites maybe struggle with the most. So this kind of talks generically a little bit about kind of how you might use data going forward when it comes to thinking about business cases, resource modeling, workforce improvement and redesign, those kinds of things. Essentially what the approach we've taken is, rather than repeating what we did, which is a very large data pool from multiple data sets, different national commissioning data sets, so emergency care, inpatient, community services and community hospitals, and SNAP data, that can be quite overwhelming sometimes for individuals that are trying to manage that amount of data. It also sometimes doesn't take a more nuanced approach, which you'll be able to do because you know your services much better than kind of anybody else. So instead, this takes a problem-based approach. So we have 4 separate Excel templates that try to answer a bit more of a specific question or hone in on a specific area within stroke services. But the important thing is that the principles of data analysis still exist within those data templates. So you are free to liaise with your business intelligence teams, your data teams, to play around with exactly what data fields are included within that template. If you know that you collect a particular data field that it would be of interest, or you know that your services run in a certain way where it would be interesting to cut the data through that data field, then by all means include that within the template, and we'll kind of explain how you might go about doing that. So each template has pretty much the same format. So we have 4 tabs. The first one is a guide. The second one is the summary, which gives you the actual outputs. The third one is the data. So this is exactly where you would paste the actual data extract provided by your BI teams. And then the fourth one is the SQL script. So this is what your BI teams would, on the whole, use to extract the required data for the template out of your own local data warehouse or your local systems. And so this takes you through, we haven't uploaded them directly here, but we have them available by Excel. So I'll show you. This takes us through the 4 that we have available here. So we have a virtual stroke ward template, which talks a little bit about identifying if it's a particular issue for you for ambulant low severity suspected stroke admissions, and if an admission avoidance model would be something that would be worthwhile for you. Stroke ward journey template, so particularly looking at the movement of stroke patients either from the stroke unit to an outlier ward or vice versa, or for the cohort of patients that unfortunately never make it to the stroke unit and are managed exclusively on an outlier ward. The stroke mimic journey template, so looking specifically at stroke patients that present as stroke presentations at the start in terms of the ED data or the inpatient data, but then leave the hospital without a stroke diagnosis with another diagnosis completely. But particularly focusing on those that are exclusively managed on the stroke ward. And then finally, a community data template that combines commissioning data sets from the community with also inpatient, and by that I mean community hospital data, to be able to cut those together and look at things like length of stay and time of first contact, etc. So what I'll do is I'll just quickly focus in on those templates here, so that we have the virtual stroke ward one here. So as I mentioned, we've got 4 tabs. This is currently populated with Lincoln's data, so when you get it, it will be kind of a blank slate in terms of the 3rd tab here. The summary gives you kind of the information that you are most interested in. So what you need to do is here is essentially just type in the date range for the data that you've extracted. You will need to put in a local bed day cost depending on what the agreed number is locally, and it will give you kind of the number of admissions for patients that would be eligible. And again, this is set based on Lincolnshire's, but you're free to change the NIHSS on arrival, the pre-stroke MRS that you would consider to be appropriate for your cohort. And then it gives you the number of eligible virtual stroke ward patients, what their total length of stay was per month, what their average length of stay was per patient, and then roughly how much that is costing in terms of a potential opportunity for admission avoidance. The 4th tab here is that SQL script that I mentioned. So this would be available to your BI teams to use to actually extract the data. I'll quickly show you a second template as well. So again, we have the data slide for the stroke ward journey, the SQL script on the right-hand side, and then the summary of the template here. So again, you would put in the kind of the date ranges that you were talking about. You would put in a bed day cost that was appropriate, and then it splits it up into patients that started on the stroke unit and ended their journey on the stroke unit, those that started but unfortunately ended on an outlier ward, those that were brought onto the stroke unit having initially been on an outlier ward, and those that never stayed on the stroke unit whatsoever. It gives you a general kind of high level overview of the number of patients we're talking about, what the difference is in average length of stay, and also what the rough cost is for their duration on the stroke unit. I'm just going to jump back to the toolkit itself just to show you a little bit more about what else is left. So we also have an innovation stage that talks a little bit about how you might bring people together to think about new ways of working and new models of care. And then this section here is a much longer deep dive into the virtual stroke ward, and if it's something that would be of interest to you, how you might go about practically implementing that. There are many chapters. It goes through workforce, through pathway overview, thinking about sizing the opportunity, if this is an appropriate cohort that is worth is a significant problem for you locally, and again it talks a little bit about how to use that specific template to get that answer, and then it goes into demand and workforce planning, thinking about how you might staff such a service and who you might need to do that, running a pilot, measuring KPIs, and thinking about finance and business case notes. The final section talks a little bit about implementation and how you might go about implementing some of the changes that come not only to the virtual stroke ward, but any other kind of new models of care or innovations that come from you running your own sort of mini CLEAR projects yourself. And then we've got some additional resources for stroke as well that are referenced throughout the toolkit. I'm going to stop sharing there. I think I'm running to time. We have 15 minutes left, and I'll hand back to Claire.
Thank you, Dan. That's great. Yeah, so really it's any questions now, I think, and over to anybody that's got any questions. We have put this QR code up, so if people are interested in testing out the toolkit data templates, please do scan that QR code or just get in touch via that email address there.
Yeah, sorry, thanks, Claire. And Amisha, if you could just leave that up for the rest of the chat, that would be great.
Sorry, guys, could you just outline to the people on the call about what testing it might look like? Other sites that might want to do that.
Sure, I can do that. So essentially, you'll get access to what I just ran through there in terms of the toolkit. So it won't be available on the Learning Hub itself. You'll get a link that you can use yourself to kind of go through the methodology. What we're really interested in is the data templates themselves. So we'll send those to you as well, and it would involve you sitting down with a member of your BI team, testing out the data template. We tested it in Lincolnshire to kind of fresh eyes, handed them the SQL scripts. I think it only took them half an hour or so of putting the data out of their data warehouse to someone that hadn't seen it before, and then some feedback from yourselves, really just to find out what the process was like. And I guess some interesting insights as well, what you've been able to identify from your own data would be really helpful. So Claire, we have some questions in the chat, and I think a hand up as well. I don't know if you want to go for maybe hands first, and then we can try answer the questions in the chat at the same time. Great.
Yeah. Okay. Is it Nina first?
Yeah.
Yeah. Hi. I just want to say, as someone who led a program like this many years ago, I so appreciate the hard work that's gone into it, because it is such a massive population of stakeholders and organizations, and it's quite complex, but it's actually, I think from that it's good because you get that participation and I suppose energy behind it to actually improve it. And I think once everyone's left their egos at the door and then work along concentrating on that, the importance of a pathway, I think you can achieve mountains. I think in terms of your methodology you use, it's exactly what I would do. And I think, there's so many places still that don't engage with stakeholders. So I just want to say, hats off to you for doing that, and what great work.
Thank you. Mahana.
Hi. Thank you for this excellent presentation. It's very interesting. Just a really question about whether there's any capacity for the same system to be trialed out in a different county, like in Cornwall, which is also a very challenged area in terms of access to stroke beds and challenges across the stroke pathway, both acute and subacute. I think the toolkit is fantastic. I think there is something about having external sets of eyes on the pathway. So just a question really over the CLEAR program.
Yeah, if you want to express your interest, we will pick up this conversation. So we can certainly do that. Is there anybody else that has got any questions, especially for the clinical team? I think it's been really interesting hearing their insights. But yeah, just wondered if anybody got any questions for the clinical team at all. Sarah.
Hi, I'm from Worcestershire. I'm just wondering, in terms of stakeholders, did you have social care engage well with this project? Because that's what is becoming a real problem for us.
Yes, we did. We held part of the engagement and work was we held workshops, and we held a community workshop with the community teams and the adult social care team in Lincolnshire. That was a morning's workshop. But we also worked closely with the social care team in the hospital as well. And that NDT work that we did on the acute stroke unit they were pivotal to that work and that change around capacity assessments and just those best interest meetings, which were causing a lot of bottlenecks in the system. Is there anything else anybody would like to ask? No. I mean, just from my point of view, it was just a great big thank you for speaking today, Amy, Sarah, Abdul and Michelle, and just for your honesty really as well around what you've learned both professionally and personally. I think that's where we get a lot of the rich data from, is seeing people and how your concept changes with your oversight to work. So I think you demonstrated that really well for us, so thank you for that. And as we say, please do get in touch if anybody is interested in the toolkit and any further work that you thought was interesting for your service. Okay. I think we'll give you all 10 minutes time back if there's no other comments, and thanks again ever so much for joining us today.